don't stop. Don't stop. Don't stop. Don't stop. Don't stop. Don't stop. Don't stop.
Intestinal obstruction, common symptoms, depending on the level of obstruction. Bowel obstruction can present with 1. Abdominal pain, 2. Swollen abdomen, 3. Abdominal distension, 4. Vomiting, 5. Fecal vomiting, 6. And constipation. Bowel obstruction may be complicated by 1. Dehydration and electrolyte abnormalities due to vomiting, 2. Respiratory compromise from pressure on the diaphragm by a distended abdomen, or aspiration of vomitus, 3. Bowel ischemia, 4. Perforation from prolonged distension or pressure from a foreign body. In small bowel obstruction, 1. The pain tends to be colicky, cramping and intermittent, in nature, with spasms lasting a few minutes. The pain tends to be central and mid-abdominal. Vomiting may occur before constipation. In large bowel obstruction, the pain is felt lower in the abdomen and the spasms last longer. Constipation occurs earlier and vomiting may be less prominent. Proximal obstruction of the large bowel may present as small bowel obstruction. Intestinal obstruction in infants. Intestinal obstruction in infants typically arises from 1. Infections, 2. Organ diseases, 3. Decreased blood flow to the intestines, strangulation. Some children experience the condition after having a stomach flu. This can cause inflammation in their intestines. Intussusception is most common in children 2 years old and younger. This occurs when one part of their bowel collapses or slides into another part. As a result, their intestine becomes blocked. Any type of intestinal obstruction is difficult to diagnose in infants because they can't describe their symptoms. Instead, parents must observe their children for changes and symptoms that could indicate a blockage. Examples include abdominal swelling, drawing knees up to their chest, appearing excessively drowsy, having a fever, grunting in pain, passing stools that appear to have blood in them, known as a current jelly stool, very loud crying, vomiting, particularly bile-like vomiting that is yellow-green, displaying signs of weakness. Causes small bowel obstruction. 1. Small bowel obstruction. Causes of small bowel obstruction include 1. Adhesions from previous abdominal surgery, most common cause, 2. Barbed sutures, 3. Pseudo-obstruction, 4. Hernias containing bowel, 5. Crohn's disease causing adhesions or inflammatory strictures, 6. Neoplasms, benign or malignant, 7. Intussusception, 8. Volvulus, 9. Superior mesenteric artery syndrome, a compression of the duodenum by the superior mesenteric artery and the abdominal aorta, 10. Ischemic strictures, 11. Foreign bodies, e.g. gallstones in gallstone ileus, swallowed objects, 12. Intestinal atresia. After abdominal surgery, the incidence of small bowel obstruction from any cause is 9%. In those where the cause of the obstruction was clear, adhesions are the single most common cause, more than half. Causes of large bowel obstruction. Causes of large bowel obstruction include 1. Neoplasm/cancer, 2. Diverticulitis/diverticulosis, 3. Hernias, 4. Inflammatory bowel disease, 5. Colonic volvulus, sigmoid, cecal, transverse colon, 6. Adhesions, 7. Constipation, 8. Fecal impaction, 9. Fecalema, 10. Colon atresia, 11. Intestinal pseudo-obstruction, 12. Endometriosis, 13. Narcotic-induced, especially with the large doses given to cancer or palliative care patients. Outlet obstruction. Outlet obstruction is a subtype of large bowel obstruction and refers to conditions affecting the anorectal region that obstruct defecation, specifically conditions of the pelvic floor and anal sphincters. Outlet obstruction can be classified into 4 groups. 1. Functional outlet obstruction, A. Inefficient inhibition of the internal anal sphincter. Black small square short segment Hirschsprung's disease. Black small square Chagas disease. Black small square hereditary internal sphincter myopathy. B. Inefficient relaxation of the striated pelvic floor muscles, black small square anismus, pelvic floor dyssynergia. Black small square multiple sclerosis. Black small square spinal cord lesions. 2. Mechanical outlet obstruction, internal intussusception. Enteroceal. 3. Dissipation of force vector, rectocele descending perineum. Rectal prolapse. 4. Impaired rectal sensitivity, megarectum. Rectal hyposensitivity. There is another classification: mechanical obstructions and non-mechanical obstruction. 1. Mechanical obstructions. Mechanical obstructions are when something physically blocks your intestine. In the small intestine, this can be due to 1. Adhesions, which consist of fibrous tissue that can develop after any abdominal or pelvic surgery or after severe inflammation. 2. Volvulus, or twisting of the intestines. 3. Intussusception, a telescoping, or pushing, of one segment of intestine into the next section. 4. Malformations of the intestine, often in newborns, but can also occur in children and teens. 5. Tumors within your small intestine. 6. Gallstones, although they rarely cause obstructions. 7. Swallowed objects, especially in children. 8. Hernias, which involve a portion of your intestine protruding outside of your body or into another part of your body. 9. Inflammatory bowel disease, such as Crohn's disease. Although less common, mechanical obstructions can also block your colon, or large intestine. This can be due to 10. Impacted stool. 11. Adhesions from pelvic infections or surgeries. 12. Ovarian cancer. 13. Colon cancer. 14. Meconium plug in newborns, meconium being the stool baby's first pass. 14. Volvulus and intussusceptions. 15. Diverticulitis, the inflammation or infection of bulging pouches of intestine. 16. Stricture, a narrowing in the colon caused by scarring or inflammation. 2. Non-mechanical obstruction, your small and large intestines normally work in a coordinated system of movement. If something interrupts these coordinated contractions, it can cause a functional intestinal obstruction. This is generally known as a non-mechanical obstruction. 1. If it's a temporary condition, it's referred to as an ileus. It's called a pseudo-obstruction if it becomes chronic, or long-term. Causes for ileus include abdominal or pelvic surgery. Infections, such as gastroenteritis or appendicitis. Some medications, including opioid pain medications. Electrolyte imbalances. 2. Intestinal pseudo-obstruction can be caused by Parkinson's disease, multiple sclerosis, and other nerve and muscle disorders. Hirschsprung's disease, a disorder in which there is a lack of nerves in sections of the large intestine. Disorders that cause nerve injury, such as diabetes mellitus. Hypothyroidism, or an underactive thyroid gland. Diagnosis of bowel obstruction. NB. Average inner diameters and ranges of different sections of the large intestine. The one main diagnostic tools are blood tests, X-rays of the abdomen, CT scanning, and ultrasound. 2. If a mass is identified, biopsy may determine the nature of the mass. 3. Radiological signs of bowel obstruction include bowel distension and the presence of multiple, more than 6, gas fluid levels on supine and erect abdominal radiographs. 4. Ultrasounds may be as useful as CT scanning to make the diagnosis. 5. Contrast enema or small bowel series or CT scan can be used to define the level of obstruction, whether the obstruction is partial or complete, and to help define the cause of the obstruction. The appearance of water-soluble contrast in the cecum on an abdominal radiograph within 24 hours of it being given by mouth predicts resolution of an adhesive small bowel obstruction with sensitivity of 97% and specificity of 96%. 6. Colonoscopy, small bowel investigation with ingested camera or push endoscopy, and laparoscopy are other diagnostic options. Differential diagnosis of bowel obstruction. Differential diagnoses of bowel obstruction include, ileus, pseudo-obstruction or Ogilvie syndrome, intra-abdominal sepsis, pneumonia or other systemic illness. Potential complications. Treatment is essential to reduce complications such as dehydration, electrolyte imbalances, perforation, or a hole that forms in your intestines, which leads to infections. Kidney failure. If the obstruction is preventing blood from getting to a segment of intestine, this can lead to infection. Tissue death. Intestinal perforation. Sepsis, a life-threatening blood infection. Multiple organ failure. Death. For some people with a chronic obstruction due to a stricture or narrowing of their intestine, a doctor may place a metal stent that expands inside the intestine using a long tube called an endoscope. The stent, a wire mesh, holds open the intestine. The procedure may not require cutting into the abdomen, and it's usually used if a person isn't a candidate for traditional surgery. Treatment of bowel obstruction. Once some causes of bowel obstruction may resolve spontaneously, many require operative treatment. In adults, frequently the surgical intervention and the treatment of the causative lesion are required. 2. In malignant large bowel obstruction, endoscopically placed self-expanding metal stents may be used to temporarily relieve the obstruction as a bridge to surgery, or as palliation. Diagnosis of the type of bowel obstruction is normally conducted through initial plain radiograph of the abdomen, luminal contrast studies, computed tomography scan, or ultrasonography prior to determining the best type of treatment. Small bowel obstruction treatment. 1. In the management of small bowel obstructions, a commonly quoted surgical aphorism is, "Never let the sun rise or set on small bowel obstruction because about 5.5% of small bowel obstructions are ultimately fatal if treatment is delayed." 1. Improvements in radiological imaging of small bowel obstructions allow for confident distinction between simple obstructions, that can be treated conservatively, and obstructions that are surgical emergencies, volvulus, closed-loop obstructions, ischemic bowel, incarcerated hernias, etc. 3. A small flexible tube, nasogastric tube, may be inserted through the nose into the stomach to help decompress the dilated bowel. This tube is uncomfortable but relieves the abdominal cramps, distension, and vomiting. 4. Intravenous therapy is utilized and the urine output is monitored with a catheter in the bladder. 5. Most people with SBO are initially managed conservatively because in many cases, the bowel will open up. Some adhesions loosen up and the obstruction resolves. The patient is examined several times a day, and X-ray images are made to ensure he or she is not getting clinically worse. 6. Conservative treatment involves insertion of a nasogastric tube, correction of dehydration and electrolyte abnormalities. 7. Opioid pain relievers may be used for patients with severe pain. 8. Antiemetics may be administered if the patient is vomiting. 9. Adhesive obstructions often settle without surgery. If the obstruction is complete, a surgery is usually required. 6. Most patients improve with conservative care in 2 to 5 days. When the obstruction is cancer, surgery is the only treatment. 7. Those with bowel resection or lysis of adhesions usually stay in the hospital a few more days until they can eat and walk. 8. Small bowel obstruction caused by A. Crohn's disease, B. Peritoneal carcinomatosis, C. Sclerosing peritonitis, D. Radiation enterithes, E. And postpartum bowel obstruction are typically treated conservatively, i.e. without surgery. Neonatal bowel obstructions, fetal and neonatal bowel obstructions are often caused by an intestinal atresia, where there is a narrowing or absence of a part of the intestine. These atresias are often discovered before birth via an ultrasound, and treated with using laparotomy after birth. If the area affected is small, then the surgeon may be able to remove the damaged portion and join the intestine back together. In instances where the narrowing is longer, or the area is damaged and cannot be used for a period of time, a temporary stoma may be placed. So, 1. For partial obstructions or an ileus, it may be possible to treat by simply resting the bowels and giving intravenous, 4. Fluids. Bowel rest means you'll be given nothing to eat, or clear liquids only, during that time. If the cause of the obstruction is known, your doctor treats that as well. Treating dehydration is important. A doctor may give you 4 fluids to correct electrolyte imbalance. A catheter may be inserted into your bladder to drain urine. A tube may need to be passed through your nose and down into your throat, stomach, and intestines to relieve pressure, swelling, vomiting. If your problem is due to the use of narcotic pain medications, your doctor can prescribe medication that reduces the effect of the narcotics on your bowels. Surgery will be required if these measures fail or if your symptoms become worse. Treatment in this case typically requires a hospital stay. You'll be given 4 fluids, because in addition to relieving dehydration, they help prevent shock during surgery. A severe complication of a bowel obstruction can be permanent damage to your intestine. If this occurs, a surgeon will perform an operation to remove the section of dead tissue and rejoin the 2 healthy ends of your intestine. While prescription medications can't treat the obstruction itself, they can help reduce your nausea until further interventions are performed. Examples of medications your doctor may prescribe include antibiotics to reduce infection, anti-nausea medicines to keep you from vomiting, pain relievers. Prognosis. The prognosis for non-ischemic cases of SBO is good with mortality rates of 3 to 5%, while prognosis for SBO with ischemia is fair with mortality rates as high as 30%. Cases of SBO related to cancer are more complicated and require additional intervention to address the malignancy, recurrence, and metastasis, and thus are associated with poorer prognosis. All cases of abdominal surgical intervention are associated with increased risk of future small bowel obstructions. Statistics from U.S. healthcare report 18% readmittance rate within 30 days for patients who undergo SBO surgery. More than 90% of patients also form adhesions after major abdominal surgery. Common consequences of these adhesions include small bowel obstruction, chronic abdominal pain, pelvic pain, and infertility.